Welcome to this segment of Pop Health. Today's topic, we're going to talk about the respiratory therapist role in donation and their impact. I would like to welcome Mo, Trine, RN, and Certified Procurement Transplant Coordinator. She's going to share some of her background and her knowledge regarding our topic today. So welcome, Mo.
Hi, Brandon. Thank you so much for having me. I appreciate being here. Just to tell you a little bit about myself and my background, I am an RN and I worked quite a few years in the trauma ICU and the neuro ICU as well as open heart surgery ICU in California. I experienced donation across the way and decided to venture into that land. That brought me here to being, for one, an ORC for Life Center and now the clinical trainer for Life Center.
Awesome. Well, it certainly sounds like you bring a ton of experience and a wealth of knowledge to the wonderful world of organ donation. So I guess let's jump in and let's talk about, why do you love your job and what brings you joy as far as in encouraging others to consider donation?
Donation is definitely a huge passion of mine. I connected the very first time I was able to take care of a donor. I watched a family go through immense grief, and despite that immense grief, they were hopeful in helping save somebody else's life. And to see people move forward and help others despite their own pain is one of the most beautiful things that you can see in human nature. So coming to donation was definitely the place I wanted to be, and being a part of it and seeing that beauty through tragedy and helping families have some kind of silver lining, if they can, to the very tragic outcome of their loved ones.
That's awesome. Well, we definitely appreciate your work in this and what you do. So being that our audience here are respiratory therapists, what would you, or how would you describe the respiratory therapist's role in donation, and how would you best describe their overall impact?
Oh, RTs actually make a huge impact in the role of donation, and I don't think a lot of RTs are quite aware of that. We rely heavily on them in a variety of areas when it comes to donation. Brain death testing and the apnea trial is a really big important step for an RT to be involved in. There's also when we start managing a brain dead donor, and then RT actually has a big role in donation after circulatory death, which is a different type of donation.
Awesome. Could you talk a little bit more about brain death testing and I guess some of the components such as apnea testing?
Yeah, for sure. I do want to back it up just a tiny bit to a little bit of physiology to kind of bridge the importance of brain death testing in the apnea trial. So the reason the apnea trial is so important in brain death testing is because it's testing a basic reflex that everybody should have. So we all know that physiologically we have key sensors in our body that essentially measure the amount of CO2 and oxygenation in our blood and kick up that number essentially to the brain and say, hey, you need to have respirations in this fashion, whether it's faster, slower, to adjust that CO2 level. Because there's that key factor and because that's part of the brain stem, it's one of the most basic and primal reflexes we have, and it's the most important piece of brain death testing when it comes to actually determining that somebody is brain dead. In order to determine someone's brain dead, it requires them to be free of any confounding factors, first of all. So hypothermia, sedation, things that could impact and mimic the look of brain death testing when someone's not actually brain dead. So we make sure and eliminate all of those factors and make sure they're not present to confound the picture. And the key point of apnea testing, the RT comes in and actually will help perform this. And one of the first things they end up doing is doing a baseline ABG. And the important piece is to make sure to measure that the CO2 is between 35 and 45 millimeters of mercury. You want a perfect baseline because you want to show that everything was normal at the time that you're attempting this apnea trial. There's also hyperoxygenating the potential donor. Making sure that their PaO2 is greater than 200 is something that's important baseline for starting the standardized testing. Then the ventilator is disconnected, and high flow, or not necessarily high flow, but oxygen is provided to the patient, and the chest is monitored for any respirations that could be occurring over the next 8 to 10 minutes. This is the actual apnea trial where we're making sure whether there are or are not respirations. And linking back to the physiology part, basically what happens is there's been some really good studies that have shown when someone is apneic, so they had patients under anesthesia that didn't have a respiratory drive because of the anesthesia. They actually kinked the tube or blocked the tube and measured the carbon dioxide levels that built up to see how much they would climb in a certain period of time. And so with that, you have CO2 that'll rise by about 12 points in the first minute and then roughly 3 points after that. Our goal with apnea testing is to raise the CO2 high enough that it would absolutely, without a doubt, trigger the reflex in the brain to initiate a breath. And that is the most important piece. So we wait the 8 to 10 minutes because if you calculate it out, that's definitely a sufficient number of points. The goal is to make sure that the carbon dioxide level either rises by 20 points or is greater than 60. The American Academy of Neurology has established that both of those are actually quite important, but most hospitals, and I believe when it comes up for the boards, for the NBRC, for the ACCS, it's going to ask for either or if that's a question that comes up. When it comes to donation, it's actually a little bit more of a combined effort of the 20-point rise and the greater than 60. And that's because we want to make sure there's no other confounding issues. So if you have somebody who is a CO2 retainer and they start with a higher CO2, and yes, say it's their CO2 is 47 at baseline, you rise up above 60, say 61, you're still not 20 points higher, which means you could not be high enough in that adjustment of CO2 to have initiated that reflex. Say in a different situation, you have somebody who has CO2 of 35 at their baseline and you get them up to the 20 points of CO2 of 55 during that apnea trial, you're actually not above 60, so you can't technically totally ensure that they're going to have that respiratory drive triggered if it was the fact. So donation purposes, we actually want both. But the key is to make sure that there's the adequate rise of the CO2 when that's happening.
What are some of the other parameters that are evaluated when in regards to the physiology? So what is the baseline or cutoff for hypothermia?
Typically, there is the need for brain death testing to occur once the patient is above 36 degrees. We definitely want to make sure that they are at a level of temperature that would be conducive for the brain to work if it could work.
And then can you describe the overall brain death donor management process?
Yeah, so RT plays a huge role in that. Once a patient is declared brain dead and donation moves forward, we actually, as organ recovery coordinators, will take over as the physician for the donor. Because they're declared dead, we can become the provider without actually having an MD behind our name. And we have really pretty rigid protocols that go into managing a brain dead donor, and we work very closely with the respiratory therapist to make sure we're doing the best thing we can for the lungs, especially if someone's going to be a lung donor. One of our most important things is we want to make sure oxygenation is happening and good perfusion. Those are the two key things, and we can't have proper oxygenation without an RT having a big role in making sure that's happening adequately and effectively. As far as management goes, we end up being pretty aggressive when it comes to PEEP maneuvers and other modes of recruitment. We want to work with any of the challenges that may come up with a donor that is having lung issues. We definitely want to include the RT and get their input on what they think is going to be the best thing to do to fix the problem. We absolutely know that respiratory therapists are the best and know the most when it comes to the lungs and ventilation, and so we can definitely tend to rely heavily on them as someone who's a good resource for us. We end up doing a whole lot of aggressive kind of pulmonary toileting. We will do aggressive CPT, and I'm talking manual CPT, vest if have to, definitely not bed.
I think we all know what's effective there.
Yes. We definitely want to place the patient in Trendelenburg. The CPT occurs about every 2 hours. We're doing high turns. We're doing albuterol treatments. We're doing suctioning. There's also having to assist with bronchs. That's very important. Making sure the donor maintains oxygenation and stability through all this is really key and important. And so the RTs have a very big role when it comes to managing or helping manage a brain dead donor.
Awesome. Some of the key words and the theme that I'm picking up from this is a lot of collaboration and interdisciplinary, just teamwork.
Absolutely. Totally. We love having collaboration and teamwork with the respiratory therapist. It makes everything go so much smoother, and we have a much higher success rate. And I really like to encourage RTs to realize that they single-handedly can help make or break someone be a lung donor and save somebody else's life with the gift of lungs. And that's all about how well that they are managing those lungs and how aggressive they're making sure those lungs stay clean and effectively oxygenating. And that all comes down to everything you guys do as respiratory therapists.
Awesome. That's brilliant. Thank you. Earlier you mentioned another type of donation. I believe you referred to as being circulatory death. Could you talk a little bit about that?
Yeah, for sure. So donation after circulatory death is a different pathway that donors can take. Either way, whenever organ donation happens, a patient has to be declared dead. They can either be declared dead by neurologic criteria, which is being declared brain dead, and that's legal time of death, or if they don't have neurological insult or injury, but they have other mechanisms that are actually going to create their heart to stop after extubation occurs. For terminal extubation, we can move forward with donation after circulatory death. In those cases, when we become involved and the family has realized their loved one is not going to survive and they want to move to removal of ventilatory support, we actually become involved, and once we get authorization for donation, we'll start our evaluation process to find the perfect matches for the potential organs. And during that time, it's really important that the healthcare team remains in charge and also does not de-escalate care. And one of the big things is you can have lung donation still occur with donation after circulatory death, and RTs having a role in lung advocacy and making sure that airway is maintained and there's still treatments going on and suctioning and all the important things that you would normally do for someone who would actually survive are the same things we want to keep going, even though this person is going to be terminally extubated. During the actual extubation process is definitely that's the RT. They play a very big role in communicating with the family, making sure the family's ready for that withdrawal of life support, and definitely knowing when not to pull the breathing tube. So we have a lot of things to prepare on our end when it comes to donation, and comfort care is managed in a way that is very controlled. So that way we can move effectively to the operating room once the patient's heart stops. So that actual moment of extubation is key. It's driven by the family, and it's also the family coordinating with us making sure we do that in a time and manner that we can actually move forward with donation once the heart stops. And RTs are key to that, and making sure it doesn't happen too early and being there for the family when it does need to happen.
Awesome. Definitely is a sense of collaboration again. So I guess my last question I have for you is, if you could walk away with one message for our future respiratory therapists and those who are working diligently in our field, what would that be?
I would really love to see RTs becoming advocates for ensuring that donation potential was reviewed before patients are terminally extubated. So donation cannot happen once that breathing tube is removed. And by donation, I mean organ donation. That's primarily what I've been speaking of here today. Organ donation cannot happen. We cannot help save lives once that breathing tube is removed. And if we could work together in RTs creating a pause, a moment to say, wait a minute, we're about to terminally extubate somebody. Was their evaluation done for organ donation, and do we need to create space for a family to have a conversation with the coordinators to see if donation is the right path for their loved one? And that happening before that terminal extubation is really key.
That's great. I think that's really important. I think that if one life is saved, that's a great deal of work.
Absolutely.
Well, awesome. Well, thank you so much for your time today, and we certainly appreciate what you've shared with us. Any last remarks or anything you would like to add?
No, I just thank you so much for having me and for being able to share the experience of donation with others, and hopefully gain some collaboration and interest in making sure we move forward and make donation happen.
Sounds great. Well, thank you again, and we'll catch you next time on Pop Health.